Hi, good morning everyone. I'm Dr. John. Today we'll be discussing about interpretation of CT brain. This was a presentation that I had made in the mid-TAPICON in the month of January 2024. So the overview of this presentation is we'll be discussing about the various ways in which we interpret CT brain and the approach to CT interpretation, few basic concepts in CT physics before we interpret it. When we give contrast and non-contrast to patients, basic cross-sectional anatomy of CT brain, few artifacts, and illustrator cases, the day-to-day cases that we see in our practice, and few review areas in the brain. So coming to how to read a CT brain, there are three ways in which we do it. There's a rudimentary approach, a more elegant systematic approach, and there is a targeted approach. What is the rudimentary approach? Rudimentary approach is very simple. You compare the right and left sides of the CT brain. So here we are able to say this is the right side of the brain and this is the left side. There's something large white which is sitting here, which is basically an epidural hematoma. So if you compare the right and left side and come to a conclusion, that is called rudimentary approach, which is what is basically done by a person who is not exposed to interpreting CT brain. A more systematic way of interpreting is by looking at not just at the sites, not just stopping at the symmetry, but also looking for midline shift, reviewing certain anatomical landmarks at each slides, namely the brain tissue, CSS space, skulls and soft tissue, then going through various windows like subdural windows and bone windows. What are these windows? We'll be coming back to those later. The final way of doing it is a targeted approach in which there is a clinical question which is before us. Maybe it is a case of trauma or it is a headache. Say for example, if it is a headache, there are a few important differential diagnoses that we'll be dealing with. It could be a subarachnoid hemorrhage, or there can be intracranial space occupying mass lesion, or hydrocephalus, cortical or dural venous thrombosis, and paranasal sinusitis. We specifically look whether these findings are present in the CT brain. So if there is a clinical question in front of us and if we try to answer it by looking at the brain, then that is called as a targeted approach. So before going into interpreting, we need to know a few basic things about CT physics, namely the windowing. CT physics is quite complicated. We are not going to deal with the entire CT physics today. We are going to understand only two important CT physics concepts, namely the CT densities, what is Hounsfield unit and what is window. For example, when we look at a CT brain, there are 5 different densities, namely bone, soft tissue, water, fat and air. In one extreme it is bone, in the other extreme it is air. These 5 different types of densities are picked up in CT. Okay, on one end the bone or metal is in the higher end where it appears white on looking at the CT brain, and on the other end it is air where air looks black. Intermediate densities are the fat, water and bone, fat and water, which are more of a grayish color. So this is a cross-sectional appearance of a CT brain. Whenever we interpret a CT brain, we cut through the section of the brain and look from the inferior aspect. So this would be the right side of the brain and this would be the left side of the brain. In a cross-section area of the brain, we are able to see all the 5 densities which we talked in the previous slide. Namely, this is the bone, 2 is the soft tissue, 3 is the water which is seen in the CSF or lateral ventricles. This 4 is the subcutaneous fat and 5 is air. As we progress from 1 to 5, we are able to see it becomes more and more blackish. So these are the 5 different parts in a single brain. So that is CT densities or Hounsfield units. Coming to what is windowing. There is a story from Mahabharata that we all are familiar with. When Arjuna was asked to shoot down a bird, he looked at the eye of the bird and he concentrated only on the entire bird. He was not able to see the tree, he was not able to see the branches, he was not able to see the hut behind, he was not able to see his friends standing there. His entire concentration was only on the eye of the bird. And so when Dronacharya was asking him to shoot, his aim was centered at the eye and the entire concentration was only on the bird. So similarly, when we are looking at a CT brain, we will be looking at it in a different manner. Say for example, there's the same CT section. Now we'll see how the single size once we change the windowing. Basically, when we change the windowing, we are making it more black, more white, different shades of gray. Okay, so in this particular window, we are able to see that there's an air foci. Now, when we change it, we are not able to see the same air foci. The bone is better appreciated in this bone window. We are able to see that there are a few areas of blackish which is seen in the bone window. So single slice, once we change the grayscale, we are able to see different structures in it. So that is called windowing. Importance of it. For example, this is a patient in which in the right side of the brain it appears totally white. But once we change and alter the window to a different thing, we are able to see between the bone and brain tissue, there is a hyperdense subdural hematoma which is seen. So this is the importance of windowing. Only on changing the window, we might be able to appreciate even important findings in the brain. So there are different windows. As we keep moving, we'll understand there's something called brain window, there's something called bone window, there's something called subdural window, there's something called stroke window. At each and everything, there is a centering at a particular Hounsfield unit, and the windowing allows us to see a certain structures which are seen within that particular brain tissue. If the window is on a higher side, 1500, we'll be able to see more structures in it. And if the windowing is very short, we'll be able to see only the brain tissue with the specific concentration to the gray matter and the white matter. Coming to the third thing, when do we give contrast and when do we give non-contrast? In a normal non-contrast CT brain, we see these 5 densities which we talked earlier, namely the brain tissue, the calvarium, the water, and the soft tissue. But we won't be able to appreciate the differentiation between the soft tissues better. That is when we start giving contrast. When we give a contrast, what happens is these are the contrast molecules from the arterial side. When we administer, it goes into the venous side. Once the blood reaches from the arteries to the vein, the contrast also reaches through it. And the arteries and veins are picked up in a better manner. Sometimes what happens is these contrasts leak out of the capillaries, especially when there is a damage to the blood-brain barrier. The contrast which we administer from the arterial side leaks into the capillaries and reaches the soft tissue. And hence the capillaries or the soft tissues are seen better. And as a result of it, the soft tissue differentiation is better when we administer contrast. Now coming to the question, when do we have to give contrast in a brain? For all practical purposes. For example, if you want to see a bleed or infarct, a plane is more than sufficient. But if you want to see an aneurysm or an occlusion of the blood vessel, then we need to give contrast. And we have to image the brain in the early phase. The late phases, after giving a contrast, we wait for some more time and then we take a CT brain. In such a case, we'll be able to see meningitis, space occupying lesions better. So if you want to identify bleed or infarct, plane is sufficient. If you want to look for aneurysm, occlusion, meningitis, and space occupying lesion, then we need to give contrast to the patient. Coming to the next thing, cross-sectional anatomy. So basic anatomy is must before we start interpreting CT brain. So normally if we see, we'll be having around 200 to 300 slices of brain as we move cranial to caudal. But in today's video, we'll be paying attention to only 8 slices. These are the 8 slices in which important structures are more crowded or more prominent, namely the centrum semiovale, lateral ventricle, basal ganglia. There's a smiley face section of the brain, there's a heart in the brain, there's a star, and there is a cellular section and the pons medullary junction. We'll see what these are. So this is a section of the centrum semiovale. Here we are able to see this is the gray matter, this is the white matter. Gray matter appears slightly grayish, white matter appears more blackish. This is a conglomerate mass of white matter is called as centrum semiovale. This is the falx cerebri, this is the bone. See, more inferiorly, this is the second slice, which is the lateral ventricle. In the lateral ventricle, what we are able to see is the body of the lateral ventricle, frontal horns. This is the corpus callosum, and this is the genie of the corpus callosum. This is the frontal lobe, and this is the parietal lobe. The third section, which is more inferior, here more important vital structures are there. This is the basal ganglia section, in which this is the caudate nucleus. This is the lentiform nucleus, which has the globus pallidus and putamen. This is the thalamus, and this black strip, which is V-shaped, is the internal capsule. This is the antelimb of the internal capsule. This is the posterior limb of the internal capsule. This is a choroid plexus, which is seen within the ventricle. This is again the ventricle. This part of the parietal lobe, occipital lobe, and this is the frontal lobe. More important structures are concentrated at the basal ganglia, which needs to be evaluated in cases of stroke. Coming to the next inferior section, namely the smiley face section. If we stretch our imagination, we will be able to see that this looks like a smile. The smile is basically the quadrigeminal plate system. This is the third ventricle. The third ventricle and quadrigeminal system is seen. This is the frontal horn of the lateral ventricle. This is the septum pellucidum, and this is again the internal capsule, and this is the genie of the corpus callosum. Here we are able to see the cerebellum, and this is the tentorium cerebelli, and this is the midline. The midbrain section is also called as the heart section of the brain, where again, if we stretch our imagination and we think, this looks more like a heart actually. So this is the cerebral peduncle, this is the midbrain, this is the suprasellar cisterns, basically the interpeduncular cistern, and here we are able to see again the interhemispheric fissure or the falx cerebri, frontal lobe, the temporal lobe, and this is the cerebellum. More inferior section, which is the pentagonal star, which was also seen in the previous section, in which this is the sylvian fissure. Again, this is the suprasellar cistern where the circle of Willis runs, and there is a falx, frontal lobe, temporal lobe, and occipital lobes. This is the pons, which appears here. Seventh section is the cella, in which we are able to see that this is the prepotent cistern. This is the dorsum cella, this is the pituitary stalk, and this is where the pituitary gland is. So any specific mass lesion should be, for the pituitary, needs to be particularly evaluated here in the axial as well as in the sagittal view. This is the frontal lobe. This is the eighth section in which we are able to see pontomedullary junction. There is a pontomedullary junction in which we are able to see medulla. Because of the CT artifacts, which we will be discussing later, the evaluation of the pons and medulla is relatively hampered or tampered in the evaluation of CT brain. This is the cerebellum. So these are the 8 important slides which we need to consider, especially when we are interpreting a CT brain. Coming to CT brain artifacts, which we ran through in the earlier slide. 4 important CT artifacts which we see in the brain. One is motion artifact. What is motion artifact? When the scan is done, if the patient is moving, we'll be able to see such streaks of attenuation which is seen, blackishness and whitishness. So that is called motion artifact, in which because of movement there is a blurry image which we are getting. Second is partial volume averaging. Partial volume averaging is basically in the thick slice, what happens is the inferior section of the bone will be part and parcel of the brain tissue, because of which we'll interpret this as a subarachnoid hemorrhage. By reviewing the thin slices, we'll be able to know whether this is actually a subarachnoid hemorrhage or there's a bone tissue that we are able to see in this section. Third artifact is the beam hardening. As and when X-rays pass through the brain, they get hardened or they get attenuated into the bone which comes across the path. So the remaining structures which are deep to the bone, namely the brain stem, will appear more blackish, and we won't be able to interpret it whether there is actually a stroke here or not. This is the reason why the posterior fossa of the brain stem is not very adequately evaluated in case of a CT. That's the reason why we ask for a MRI brain in case of a posterior circulation stroke. Fourth artifact, the streak artifact, is just a basically extension of the beam hardening. Because of the beam hardening, what we are able to see is there is various streaks which are coming out of it. So this is again obliterating the entire posterior fossa. Moving on to the illustrated cases. So I have listed some of the cases which we will be seeing in our day-to-day life. I divided into 6 sections, namely trauma, infection, brain herniation and edema, headache, stroke, and tumor. So coming to trauma, so here we are able to see a patient who has had trauma. Let's review the images. As we move cranial to caudal, we are able to see that there is a subdural hematoma, there is a brain contusion, there's few foci of pneumocephalus. As I'm changing the window, we are able to see the subdural hematoma better. So that is the importance of brain window. Again, this thin subarachnoid hemorrhage is better visualized as I change the window. So coming to how we interpret it in a CT brain, we look for extraaxial blood, we look for intraparenchymal blood, we look for any midline shift, how the ventricles behave, is there any scalp swelling which will indicate the site of impact of the brain, any fractures, presence of pneumocephalus and craniofacial sinuses. So this is a patient in which we are able to see an elliptical kind of an appearance of a white blood. Blood is very easily picked up in CT brain which appears white. So this is an extradural hematoma which is seen here. Few areas of contusions are also seen in subarachnoid hemorrhage. This is a subdural hematoma in which it appears more of a sliver of a tissue. EDH has a convex inner border, whereas SDH has a concave inner border. This is subarachnoid hemorrhage where there is a blood in the sulci. This is an EDH-SDH combination which is seen. This is the same patient. Again, when we put a bone window, we are able to see that there is a fracture line which is seen in the occipital bone, which is not seen in the subdural window. So we need to change the windows to appreciate the different findings in the brain tissue. This is a depressed comminuted fracture which is seen here. This is hygroma where we are able to see fluid collection surrounding the bilateral frontal lobes. This intraventricular hemorrhage in which there is a hyperdense blood which is seen within the lateral ventricles. Contusions where there are multiple small hyperdense hematomas which are seen in the bilateral frontal lobes and the right temporal lobe. This is diffuse axonal injury in which we are able to see tiny punctate foci which are seen in the gray-white matter junction. There's a gray matter, white matter. Exactly at the junction, we will be able to see this linear and punctate kind of an appearance, which is diffuse axonal injury. Carotid dissection, another finding that we see in trauma, in which there is a flame-shaped appearance which is seen in, and there is an absence of contrast opacification at the segment with a focal irregularity and maybe a small pseudoaneurysm also. Keratico-cavernous fistula, on administration of contrast, we are able to see the superior ophthalmic vein is bilaterally prominent. The cavernous sinuses are enlarged. So this is keratico-cavernous fistula. Trauma, the other findings are there is a brain herniation and edema. Here we are able to see a midline shift. This is subfalcine herniation and this is diffuse cerebral edema. We'll be again coming to brain herniation and edema later. This is pneumocephalus in which we are able to see air foci within the brain tissue which is forming a Mount Fuji sign, which is more in favor of a tension pneumocephalus, which points out to the fact that an urgent neurosurgical referral is needed. Coming to leptomeningeal, a patient who has a fracture in which the CSF containing structures leak out and it presents as a boggy pulsatile mass lesion. CSF leak, these are things which we see in the post-traumatic sequelae or follow-up cases. In CSF leak, we are able to see contrast which is administered in the subarachnoid space moves into the right sphenoidal sinus, which means that there is basically a break in the roof of the sphenoidal sinus. Duret's hemorrhage, whenever there is a brain herniation, brain compression, we'll be seeing parallel areas or streaks of hemorrhage which is seen in the brainstem, which has a very poor intended prognosis. Encephalomalacia is when we are able to see a large or small areas of atrophy of the brain with replacement of the brain tissue by the CSF containing by a CSF kind of an appearance. That is encephalomalacia, which is a sequelae to any insult, be it a infarct, be it a trauma, be it an hemorrhage. So moving on to the next one, which is brain herniation. So before going to brain herniation, let's know what are the different types of brain herniation. One is subfalcine, in which the underneath the falx cerebri, we are able to see brain tissue, which is a cingulate gyrus which goes through it. Then there is an extracranial herniation in which through a defect in the skull, we are able to see brain tissue which is going out. Central descending tentorial herniation in which the central part or the brainstem herniates. Lateral DTH is when the uncus of the temporal lobe herniates. Then there is tonsillar herniation in which the cerebellum part, that is a tonsil, which herniates through the foramen of magnum. There is ascending transtentorial herniation in which the cerebellum through the tentorium cerebelli moves superiorly into the supratentorial compartment. Coming to this, so these are the 5 herniations. We'll be discussing about each individually. Subfalcine herniation, how do we draw a midline shift? Go from the anterior part of the skull to the posterior part, draw an imaginary white line. From the white line, you draw a line reaching till the septum pellucidum. Here we are able to see the septum pellucidum. So this distance is going to be called the midline shift. Important cutoffs are 3 mm, 5 mm, 10 mm. More than 3 mm is midline shift, 5 mm is like significant midline shift. More than 10 mm, the patient will be having a severe kind of a midline shift requiring for a urgent neurosurgical referral. So here there is a large hematoma and there is a contusion which is causing the midline shift and subfalcine herniation. So the importance of brain herniation lies in the fact that when the brain gets herniated, there are important structures or important arteries which gets compressed, resulting in stroke. So here, if you are able to see in the subfalcine, this is a cingulate gyrus, this is the ventricles, and this is the septum pellucidum. So once it starts moving, the ipsilateral anterior cerebral artery is compressed, and because of that, the patient will land up with a stroke. So this again is subfalcine herniation, case of subfalcine herniation in which the right lateral ventricle is small and the left lateral ventricle is large. This typically occurs because of compression of the foramen of Monro. So once the mass effect causes compression here, this gets compressed and this gets dilated. This again typical of a subfalcine herniation. Moving on to the second herniation, which is the uncal herniation. Here again, because of the same hematoma, apart from subfalcine herniation, what we are able to see is that there is an extra tissue which is seen here. You can compare here with the opposite side. This extra tissue which we see here is the uncus of the temporal lobe, which is basically the uncal herniation. So when this extra tissue comes here, if you see what is the structure which is running here in this brain herniation, it is a posterior cerebral artery. So once the posterior cerebral artery runs here, on compression it lands up in a posterior cerebral artery stroke. So there is an obliteration of the supracellular ipsilateral system and there is a widening of the ipsilateral cerebellopontine angle. These are associated findings which we see in uncal herniation. This is right ankle herniation in which because of the compression we are able to see this patient has landed up in a posterior cerebral artery stroke. We'll come to stroke a little bit later. Ascending transtentorial herniation. Here we are able to see that the entire superior cerebellum, because of an infarct, it is pushing and trying to come out through the tentorium cerebelli. So this is a stroke which is pointed as a cytotoxic edema which appears in the star-shaped area. This is obliteration of the quadrigeminal system. This is the finding that we see in case of an ascending transtentorial herniation. The normal quadrigeminal system, in the normal anatomy we saw it looks like a smiley face. If the smiley face gets obliterated, if there is no more smile, then it suggests an ascending transtentorial herniation. With that, there will also be hydrocephalus, which is appreciated at the temporal horns of the brain. Transallar ascending brain herniation. Here we are able to see this is the normal appearance of the left sylvian fissure. Right sylvian fissure, if you see, there is something called morphological rectification. Because of the edema, it pushes the right sylvian fissure anteriorly, resulting in a displacement of not just the sylvian fissure but also the associated right middle cerebral artery, which might lead to a right MCA infarct. Moving to transallar descending herniation, same thing. Instead of moving up, if there is a supratentorial lesion, it will push it down. So in which case there is a frontal lobe mass with vasogenic edema which causes posterior displacement of the right MCA. This is a normal appearance of the left MCA and left sylvian fissure. Here, because of the displacement, the right sylvian fissure is displaced posteriorly. So the sylvian fissures are the important landmarks for transaxillary descending herniation, transaxillary ascending herniation. Moving to the fourth herniation, which is the tonsillar herniation. This is the section of the foramen magnum in which we are able to see that there is an extra tissue which is coming here. This is a normal CSF space which we are able to see. Here it gets obliterated because of the descent of the tonsil. It is easily picked up in the case of a sagittal brain, in which we are able to draw a line between the posterior margin of the foramen magnum and anterior part of the foramen magnum. And if there is a descent of more than 3 or 5 mm, we will call it as a tonsillar descent. If this tissue is reaching below, we call it as tonsillar descent. Extracranial brain herniation, this is something that we commonly see in case of a post-cranioplasty or post-craniectomy patients, in which the defect of the bone allows for the brain herniation to occur extracranially. Summarizing, these are the 5 different types of brain herniation, namely subfalcine herniation, descending transtentorial brain herniation, ascending transtentorial brain herniation, tonsillar herniation, and transcranial brain herniation. Moving to the third finding, that is brain edema. So if you see brain edema is classified into 4 different types, namely cytotoxic edema, vasogenic edema, interstitial edema, and osmotic edema. So in cytotoxic edema, what happens is the great white matter differentiation gets lost. In vasogenic edema, it gets attenuated. In interstitial edema, it is the periventricular white matter which is more commonly involved, and in osmotic edema, it is the pons or the brainstem. How does it look? In cytotoxic edema, the gray white matter differentiation gets lost. So here we are able to see this is a gray matter, this is a white matter. Here it is all replaced by a single wedge-shaped triangular kind of a hypodensity, in which there is a loss of the gray white matter differentiation, which is manifested, which is how a cytotoxic edema looks. In vasogenic edema, the gray white matter differentiation gets accentuated. So here we are able to see the white matter better, subcortical white matter, deep white matter, periventricular white matter is clearly seen. This is because of fluid which is accumulating within the white matter. So that is called as a vasogenic edema. Interstitial edema, the place we look for is the periventricular aspect of the frontal horns on the temporal horns. It leads to blurry, fuzzy kind of an appearance. There is a rounding of the frontal horns and rounding of the temporal horns. All this is suggestive of an interstitial edema, which basically means that this hydrocephalus or dilatation of the lateral ventricles is acute in onset rather than a chronic etiology. Osmotic brain edema typically occurs in the brainstem, namely the pons. The pons here is seen to appear more blackish or edematous when compared to the rest of the brain tissue. This is easily picked up in case of an MRI brain. Here we are able to see a vasogenic edema, cytotoxic edema, osmolar edema involving the brain stem or the pons, interstitial edema which appears as a periventricular ooze. Moving on to the fourth subset of illustrative cases, namely headache. So this is a typical example where the targeted appearance of interpretation of CT brain is helpful. So whenever we look for a CT brain, there is a checklist that we have, which integrates our systematic approach. With that, we are going to look at specific things, namely the blood in the basilar systems to look for subarachnoid hemorrhage, look at the ventricles to see whether there is any enlargement, or it might be small also. Patient might have a headache and it might be small, and it might be because of idiopathic intracranial hypertension. Brain parenchymal distortion because of mass, edema, hemorrhage, and vascular malformation, cerebral venous thrombosis, and sinusitis. Let's see these examples. So this is a patient who's having a cortical venous thrombosis. As we move cranial to caudal, we're able to see that there is an hypertense tubular structure, which is basically a cortical vein. So that is how a cortical vein thrombosis looks in a plain CT brain. This is a case of dural venous thrombosis. Again, what we are able to see is As we move cranial to caudal, let me stop at this slide. Here we are able to see the structures which are hyperdense, isn't it? This is which is hyperdense. And the same thing on administering contrast also we are looking at it. So as we move inferiorly in the plane, it is appearing hyper. And we move inferiorly, we are able to see that there is a filling defect. The left side of the dural sinus is appearing white, whereas the right side is appearing more blackish. That is because of a thrombus which is sitting within the dural sinus. There is also vasogenic edema. This is again the thrombus which is shown here. There is a filling defect anteriorly also, and there is a hematoma which is seen in the left frontal lobe. Here we are able to see the hematoma in the left frontal lobe. Another important cause of subarachnoid hemorrhage is namely headache subarachnoid hemorrhage. As we move cranial to caudal, we are able to see the sylvian fissures which are loaded with blood, preponderant systems again which are showing blood, interhemispheric fissure. All this points out to a etiology of a aneurysm. So this is how CT angio looks. After administering a contrast, we are able to see a bulbous tubular structure seen here. This is basically an anterior communicating artery aneurysm which is seen. So as we rotate it, we will be able to see it better. So this is the right and left anterior cerebral arteries, middle cerebral arteries, bilateral intercarotid arteries, basilar artery, and vertebral arteries. Other important causes: acute or chronic sinusitis, in which there is an airflow level which is seen in the left maxillary sinus, which is suggestive of an acute sinusitis. Patient having acute sinusitis will also have pain. Chronic sinusitis also will have pain. This is a typical example of a space occupying lesion in the brain which is leading to headache. We'll be coming to tumors shortly. Yeah, tumors. Here we are able to see again. Let us scroll this and see. As we move from caudal to cranial, there is an hydrocephalus. There is an area of hyperdense soft tissue tumor which is seen here in the right frontal lobe, which is causing obstruction, hydrocephalus, and periventricular ooze. There's another patient. Again, as we scroll, we are able to see there is a ill-defined hypodense lesion. So this is what we are able to see, that there is a small hypodense lesion which is seen at the foramen magnum, which is resulting in dilatation of the lateral ventricles. So sometimes it might be hypodense or isodense, in which we have to change the window, or based on the associated findings we'll be able to see that there is a dilatation of the lateral ventricles. This is a case of a tumor. Let's again scroll it and see. As we move from cranial to caudal, there's a well-defined mass lesion. All tumors cause disruption of blood-brain barrier, which results in the beta-accentuated cravite matter differentiation, that is vasogenic edema. Moving on, again we are able to see that there is a multiple soft tissue lesions. See, the appearances in tumor at many times will be because of the associated findings. For example, this is a subtle case in which, because of the edema, we are looking at more carefully whether there is an associated mass lesion. There's an edema again here. Because of it, we will be concentrating whether there is a mass lesion underlying. This is the same patient in which we have changed the window. Now we are able to see the mass lesion. So definitely there is a rounded mass lesion which is seen here, which is picked up by the presence of the vasogenic edema. So vasogenic edema in a tumor helps us in identifying the areas of tumors. But again, the important thing is not all brain tumors. For example, if it is a cortical tumor in which there won't be any blood-brain barrier breach, then the patient wouldn't be having any visible vasogenic edema. So again, we change the entire window. Now it is even better seen that there is a hyperdense mass lesion. Now obviously we are not able to see the vasogenic edema actually. So this is again windowing, a typical example of windowing. Coming to stroke. Stroke is something which we routinely do for in our day-to-day practice. This is something that we commonly see actually. So again, let us scroll this. The important reasons why we do a stroke imaging is to rule out hemorrhage. Here we are able to see that this large parenchymal hematoma with intraventricular extension. So this shows that this patient is having a hemorrhage, so we shouldn't be thrombolizing this patient. So the role of NCT brain is primarily to rule out a hemorrhagic stroke. Ischemic stroke itself is a entity which needs to be discussed in detail, but let us just concentrate on few things alone. So as we scroll, let's see what we are seeing in this patient. So this is an area in which the gray-white matter differentiation is lost, which is suggestive of an acute stroke. This is a very important finding. The hypertenuating brain tissue. Obscuration of lentiform nucleus is something that we see in case of an M1 stroke, not necessarily in other strokes. It occurs only in an M1 or a middle cerebral artery stroke. Third thing is the dense MCA sign. We'll be discussing about this. This is a very important sign, or maybe this is one of the most important things that we need to look for in a case of a stroke. Then there is the insular ribbon sign and sulcal effacement. Having said that, don't bother yourself in learning all the signs except for the hyperdense artery sign. Second thing is, if there is no bleed clinically and the patient is having stroke, go ahead and take a call whether you need to lyse the patient or not. And these are signs which we'll be able to see only in the stroke window or a more accentuated brain window. If you're seeing the above signs, it means the patient is way beyond the lysis window. So this patient might not be able to go for a lysis or mechanical thrombectomy. There is something called tissue window and there is something called time window, which we'll again discuss later. Hypertensive MCA sign. This is the only sign of all the ischemic signs I want you to remember. If you see the right Sylvian fissure, we are not able to see any white tubular structure, whereas on the left side we are able to see that there is a hyperdense structure. All arteries and veins will inherently have blood and the blood will appear white. But it is the comparison with the opposite side which tells us whether this is a hyperdense artery or it is a normal artery. It's highly unlikely that the patient is going to have a bilateral MC stroke. Not impossible, but it is highly unlikely. So compare it with the opposite side, and if it appears more white, it is a hypertensive MCA sign. And if you have an hypertensive MCA sign, this is a patient who will need a mechanical thrombectomy, provided the tissue has not gone into infarction. Okay, it needs an urgent referral for mechanical thrombectomy. Immediately inform your neurologist, immediately inform your interventional radiologist, and further imaging is needed. Coming to what we do in stroke, the recent days we have gone into something called penumbra imaging. What is this penumbra imaging? Penumbra is basically the concept in which let us just wait for a few things before we go into this exhaustive time frame windows and all those things. So if a patient is having a penumbra, it means there is a salvageable brain tissue which can be saved provided we do something. That something could be IV thrombolysis, that something could be mechanical thrombectomy. It can be anything. There is a tissue which is at risk which can be saved. So that is penumbra imaging. That is the most important thing about stroke imaging. I'll you can go through this list. Actually, we'll be discussing this list in a separate presentation of how we go about a stroke. It is just an overview to say that stroke is not just hemorrhage and ischemic. If it is ischemic, there are various things that we look in it: the diffuse criteria, the Dawn criteria, the diffusion perfusion mismatch, the aspects ratio, if there is an emergent large vessel occlusion. These are various things we look at in stroke imaging in our practice recently. Just an overview of it. For example, there's something called aspects, CT Alberta scoring system, in which various parts of the middle cerebral artery areas are given number. This is M1, this tissue is called M2, this part of the brain is called M3, M4, M5, M6 as you go more superiorly. So there are 6 points which are given to this middle cerebral artery, frontal and parietal and temporal lobes. Then there are 4 more structures, which is the caudate nucleus, the insular cortex, the putamen, and internal capsule. As and when each and every tissue gets infarcted, from 10 we keep subtracting one entity, and the final score is given to the patient. Say for example, in this patient there's only 1, 2, 3, 4, 5, 6. 10 minus 6, this patient will be having an aspect score of 4. So as the aspect scores keeps coming down, the prognosis is going to be bad. So that is the importance of this CT aspects or MR aspects. So this is a patient in which only two small areas of diffusion restriction is seen. This is better appreciated in MRI where it is called MR aspects. Penumbra imaging. For example, if the patient is having an MC occlusion, there is already an infarct. So which is seen in the diffusion. Now the question is, opening up or recanalizing this patient, will it be of any help? That is when we do the penumbra imaging, in which we try to identify for a perfusion diffusion mismatch. Here we are able to see the circle red color areas having less blood supply when compared to obviously the right side. Here there are areas which are appearing less perfuse, which is pointed by this red areas in it. But if you see the diffusion weighted imaging, there is no corresponding area of infarct, which means this is at risk, and if you do something, the patient might not land up at an infarct at a later time scale in this patient. So that is penumbra imaging. So this is how we do. So this is a diffusion flare mismatch. There's something called diffusion perfusion mismatch, and this is a diffusion flare mismatch. Many of the times we really do not know at what point the patient landed up in an infarct, because sometimes it might be a wake-up stroke, sometimes there would be no attendant to tell us what the patient, when the patient went into an infarct, the patient will be aphasic. So that is when we use the diffusion flare mismatch. If we are able to see an area of diffusion and there is no corresponding area of flare changes, then there's a diffusion flare mismatch. You can go ahead with an IV thrombolysis. Okay, so in this patient there's a diffusion area of abnormal. There's a more inferior section. There's a subtle flare hyperintensity which is seen. This is a MR angiogram image in which the right intercarotid artery is not at all seen. The right middle cerebral artery is not at all seen. Again, we did a CT angio. The same findings are confirmed. There is an attenuated caliper. So always an MR angiogram overestimates the occlusion, and this is the right intercarotid artery which is small in size when compared to the left intercarotid artery. This is on DSA. We are able to see that there is a sluggish flow, and beyond the cavernous segment we are not able to see any flow into the right side of the brain. So in this patient we did a mechanical thrombectomy. We removed it out. This is the right middle cerebral artery territory which is seen post recanalization. Coming to the last part of the illustrative cases, namely infections. Infections, for all infections, it's better that you give a contrast to see for the various abnormalities. So this is a patient in which we are able to see meningitis where there is a leptomeningeal and pachymeningeal enhancement here. This is a case of a subdural empyema. It just looks like a subdural collection, but the only extra thing is that there is an enhancement of the dura which is seen here. Abscess, in which there is a cystic lesion with the peripheral enhancement which is seen here, and there is an extension and compression of the adjacent left frontal lobe and temporal lobe. Ventriculitis, the normal ventricle will not show any enhancement. If the ependymal layer of the ventricle is showing enhancement, that is called as ventriculitis. NCC, a solid cystic lesion, tiny, small, soft tissue scolex which are seen within the cyst. So that favors an NCC. Hydatid cyst, in which there is a cystic lesion with variable hyperdense marble kind of an appearance, which is hydatid cyst. Toxoplasma, the typical target sign, black, white, black, white, black. So this is better picked up in an MRI. So this suggests of a toxoplasmosis. Japanese encephalitis or any flavivirus, the basal ganglia gets involved and hypodense. This is the area of thalamus which is involved in case of a Japanese encephalitis. HSV encephalitis is more of a temporal lobe involvement. Tuberculosis. Tuberculosis is one thing which has multiple findings, namely basal exudates. This is just looking like a subarachnoid hemorrhage. If you see it in an NCT, it is a subarachnoid hemorrhage. After administering contrast, if you see a enhancement of the circle spaces, then it is basal exudates. Tubercular abscess, again, this is just like the bacterial abscess, but it is more smooth and thin-walled actually. They also present as granulomas, caseating and non-caseating granulomas with associated vasogenic edema. Coming to the last section of the topic today, namely the review areas of brain. There are certain areas in the brain which are considered to be review areas, namely the tentorium, orbit, globe, retropharyngeal space, foramen magnum, skull base foramina, middle ear and paranasal sinuses. These are areas which we normally tend to miss, or many of the missed findings are present in these areas. So once you're done with the interpretation of the CT brain, you have to go through these areas specifically to look for any findings which you could have missed. This review areas gets increased as soon as you get reported. Which are cases you are missing in your CT brain, you can add on to this list. It is a personalized comprehensive list that you have to create for your own day-to-day practice based on the areas that you normally miss. So these are the various areas. Tentorium, there's a subtle tentorial bleed which is seen. There is an orbit in which we are able to see a hemorrhage, which is hemorrhage here. There is a large soft tissue mass which is seen in the retropharyngeal space. The foramen magnum and skull base foramina. There's a middle ear where there is a coalescing mastocytus which is present. Paranasal sinuses and sinusitis. So these are the various review areas of the brain. So to summarize what we have been discussing in the last 45 minutes, we learned how to read CT brain, the various ways of doing it, namely the rudimentary approach, systematic approach, and a more efficient targeted approach. We learned two important concepts in CT physics, namely windowing and Hounsfield units. Then we learned when to give contrast and when to give when to just do a non-contrast brain. We learned about the cross-sectional anatomy. Instead of going through 200, 300 anatomical areas of slices in the brain, we learned that 8 slices in the brain are sufficient to pick up nearly 80 to 90% of the abnormalities. So if you're a beginner, could just try to concentrate on these 8 cross-sectional slices in the brain. We learned the 4 important CT artifacts. We learned various illustrative cases that we'll be seeing in day-to-day practice, namely stroke, headache, tumors, brain herniations, infarcts. These are various things that we saw, and we concluded with various review areas or hidden areas in the CT brain interpretation. These are my references from David Schwartz and Brad Helms. There's a very good article in the net. You can see Understanding Brain Herniations. My sincere thanks to Meenakshi Sundaram sir, who gave me this opportunity to present in TAPICON conference. To Dr. Praveen, my friend from CMC Vellore, who helped me with the material for this PowerPoint presentation. And for my wife, who allowed me to do this presentation.